Good evening, members, guests of the SPR, friends. Thank you for staying so numerous in this late time of the day. The title is, and thank you for Chiesi to put it together, this interesting symposium. I've been asked sort of to say something on optimizing surfactant. You can optimize delivery, but I will not talk about delivery as there are better person, more knowledgeable person than me at talking about delivery, but I will talk about mainly dosing. And I should start by saying that surfactant therapy is great. As it revolutionized neonatal respiratory care over the last 2 decades, there have been a lot of study, multi-center, control, and many of these has been subjected to meta-analysis. This is a paper from 20 years ago from Alan Job, New England, showing clearly that mortality in pneumothorax was reduced with surfactant. And 20 years later, roughly, if you read in the Express study from Sweden, you see again that lower risk of mortality was associated with tocolytic treatment, being born at level 3, but receiving surfactant at 2 hours. So we have really a very potent drug. However, there is a problem, and I took these complex slides, I will not go through, but this is the Kurpak study that basically to me shows that either you are intubated and get surfactant, and then you get extubated, or you get CPAP and start surfactant intubation when needed. At the very end of the story, 2/3 of the baby are doing well, and 1/3, regardless, is stuck with the tube. So we do have a problem. And we believe that the problem could be surfactant, which is a fascinating compound, has a very complex metabolism. Something could go wrong in the synthesis, in the secretion, in the spreading, and probably surfactant, as you know, surfactant is many compounds, phospholipid, different proteins, and so on. So it's a very fascinating area of research, at least to me. And when you get this type of lung, you get yelling membrane disease, you get this exudate, you really wonder what is wrong. Is that surfactant? Which component of surfactant? Is the primary lung disease? Is the water content? And perhaps more. What I think is also important is that we treat all babies the same way. We give the same dose to everyone. But if you look at the different conditions that may benefit from surfactant, you have RDS, but RDS has different severity, is subject to different ventilation style, you can be in a different phase of the disease, you may have some degree of chorioamnionitis on top and other conditions, but also alteration of surfactant has been described in congenital diaphragmatic hernia, bronchopulmonary dysplasia, pneumonia, and so forth. So it's really, there are probably more disease entities. And I will make a point in my later part of the talk that are important differences we should take note of, or should take in consideration. So because of this interest, we thought we use stable isotope, which are naturally occurring isotopes, they're not radioactive, to label surfactant. So we could do kinetic study in humans. And basically what we've been successful in doing 20 years ago, we managed to label exogenous surfactant. If you give exogenous surfactant intratracheally, as many of you are still doing, you can label the lung, the surfactant delivered, the exogenous surfactant delivered to the lung. If the baby is intubated long enough, that these days is more and more difficult, you get this type of curve, and from decay you can measure half-life, from here you can measure distribution. And if you get good data on distribution, according to the Fick principle, little surfactant, high concentration of the tracer, a lot of more surfactant, more dilution of the tracer. You can estimate how much surfactant you have in the lung. As we start to look at the first results, we were a bit concerned and say, whoa, what a variation there is. And some people that were skeptical of our method, they said, ooh, it's a very variable method. We do not think it's a very variable method. We think the surfactant metabolism is very variable among subjects. These are 2 subjects that have a relatively similar half-life, you see here. But please look at this subject, how quickly decay occurs. And as a matter of fact, this patient needed a second dose. Furthermore, we have a very strange baby. This is 23-weeker, 200 milligram. You give the label, and for 2 days, there's no exchange of the exogenous surfactant with the intrapulmonary surfactant. Basically, the exogenous surfactant floats in the lung. There is no reuptake, no exchange. And I can bring many different examples of this. So this is just to make a point that surfactant metabolism can be very different among patients. Of course, we aim at comparing surfactant kinetics with gas exchange, and the parameter you will see in some of our slides is oxygenation index as a proxy of severity of patients. And also we hoped, and we have data to relate early surfactant response to the course of respiratory disease in the first 2 weeks of life, as done by Lon some years ago. So our first study, I want to bring 3 examples of our first study. The first one, compare the pool size of baby with RDS compared to control, 5 milligram compared to 65. Big difference, not big deal. If you have RDS, you have little surfactant. But what was already a bit more interesting is that when we look how much surfactant there was in the lung, the babies that need a second dose, they are only 15 compared to the 5. But we gave 100, we gave 200. So the first kind of information came out. You give 100, you give 200, but if you need a second dose, you are only 15. So probably surfactant was not retained in the lung as much as we thought. It's clear, it's oxidized, or it's not retained. In this second sort of paper, we look whether surfactant is important a bit later in the course of the respiratory condition. And we look at the amount in baby that were recovering for RDS and they're being extubated. So we assess surfactant pool before extubation, and we relate it to respiratory success or failure after extubation. Here we have baby that had to be reintubated or experienced significant respiratory failure after extubation. This in green is respiratory success, and this is the baby we meant to extubate, but we did not because the clinician decided it was not time to extubate, although we measured the pool size. And the pool size, 20 milligram, in the baby that experienced significant respiratory distress after extubation was significantly lower, smaller, than the baby that had better breathing when the tube was pulled out. So we think it does play a role in that condition. Furthermore, we play, and we did a study with 100 or 200 milligram, and I have to say that most of our studies are done with poractan alpha, as this is the only surfactant that is marketed in Italy, as the surfactant we prefer to choose for our studies. And we gave 200 milligrams compared to 100, and we reciprocate the results that Dr. Ramanathan already had published 2 years before, that if you give 200 milligrams per kilo, the chance of redosing is much less than with 100. But also because we did the kinetics, we could demonstrate if you give a higher dose, you have a longer half-life, whether it's the first dose or the second dose. And this was, sorry if I go back, and this was an important study because after in 2009 we came up with this result and we confirmed RAM study, we changed our policy in the unit from 100 and 200. I will show some data, that is derived from this change in practice in our unit. We look also in pneumonia. In surfactant pneumonia, you see in pneumonia, the half-life is extremely short compared to control, and the amount of intrapulmonary surfactant is significantly smaller compared to controls. So baby with pneumonia has significant surfactant alteration, and I speculate that if we knew, or the people did the study on surfactant supplementation pneumonia knew this information, had this information, their dosing and their timing would have been probably different. As you know, some of the studies show transient benefit, but they fail to show a positive outcome on major clinical outcome. Another approach we are taking now, and I'd like to share with you, is we try to quantify surfactant response. So in a typical situation, we see the baby deteriorating until it reaches an oxygenation index of 5. Then this is the time when it gives surfactant. We assume that the oxygenation index would stay the same for 12 hours, which is an assumption. We gave surfactant, and if the oxygenation index goes like that, we can calculate what they call it oxygenation age gain, which is this area basically reflects the improvement in gas exchange that follows surfactant. If you give surfactant and the patient gets worse, that can happen sometime, this is OI loss and quantify the deterioration, but it fortunately doesn't happen so often. Furthermore, we define the response to surfactant in green patterns, which means in the next 6 hours of surfactant, you have at least 3 values less than 25 FiO2. An orange pattern where you see 3 values less than 35. And the red bad pattern when you get no value less than 35. On top of that, regardless of the initial response, we look at the relapse, and we are able to measure with an equation the relapse, so the deterioration after treatment or after response. In a more sophisticated model we are doing with our mathematician, we calculate, when possible, the nadir, so the time for surfactant to the best oxygenation index. We can calculate this decay with the tau, and the tau indicate the speed of response, and A plus B is the severity of the condition before surfactant, and A is the residual disease. And later on, if there is a relapse, is a linear regression that can be calculated and quantified. We apply this criteria in a relatively large cohort of babies. These are the babies born in Ancona from January 2004 to June 2013. There are 980 between 24 and 31 weeks. Exclusion criteria, in the interest of time, you can read it for yourself. And 879 babies were analyzed for surfactant response, were analyzed for this particular study. This is the total number, male, female, gestational age, birth weight, Z-score. In our setting, our BPD rate, according to Walsh, is relatively low. It's 14% in this population, and death is about 8%, which so it's, I think, is an acceptable figure. The babies who got surfactant were nearly 500 for a total of 700 doses. And this is the percentage of 1 dose, percentage of 2 doses, percentage of 3 doses. So a significant number of surfactant administration. The first point, realization, is that we discuss a lot about threshold, when it's given, and so on. But we look back in our series, please note that these are the percentage of babies that got surfactant according to oxygenation index, so severity segments. These are mild condition, this is severe condition. And please note that we believe we give surfactant at 30, 40, VO2. But if a baby gets in with 70, he gets surfactant at 70. And there are a significant number of patients that get this. And if we want to do a trial, we have to be aware of this variation. So it's not due to physicians that are not very accurate. It's just that RDS present with different degrees of severity. And the results, this graph illustrates respiratory severity, OI, oxygenation index, versus our treatment. Again, note, please, there is an inverse significant correlation. If you're sicker, you get treated earlier. If you are less sick, you get treated later. This is a big problem. It's a big confounder, because if we try and plan to treat later less sick babies, we don't know what is going to happen. I mean, eventually, it turns out in the model, the later you treat, the better the outcome. And this can be a very confusing issue when you read the literature. So we have to better understand what is happening in clinical practice regarding this point. So I said before, we look at the response. This is 0 improvement, 20% improvement, 40% improvement of baby that reach air. And in our regression model, please note the surfactant dose at a significant high, these are the odd ratio, for better response. This across to all the definition of response. Severity before treatment is highly significant. Late onset sepsis has a detrimental effect on surfactant response. And this is also highly significant. These other parameters are really variable. We also model the need for redosing, and surfactant dose, predosing, or higher pregnancy-induced hypertension were associated with a higher risk of redosing, either in this model or in this other model. And those is all highly significant. We also played in the baby whether we had the half-life to see whether a shorter half-life in this model could predict redosing, and this is significant, is in the model. And now we have a model that with a prediction of 0.917 according to a Hosmer-Lemeshoff test, and these are all the variables associated with the risk of de-dosing. So we have a bit of a prediction model, or we have more a prediction model for redosing. As I alluded before, or I said before, as we became aware of a few redosing in 2008 or so, and we look at the paper by Ramanathan on the different effect of 100 versus 200, we changed policy in our unit, and in the middle of 2000 and end of 2008, early 2009, we switched from 100 to 100. This is a case control study in our unit. There was no change in policy, no change in antibiotics, no change in rate of sepsis. As far as I know, that was the only change in clinical practice we introduced. And please note that the numbers are adequate. These are a bit the demographic of the patients. You see for yourself, there are no difference between these two groups. Prenatal risk factor or associated condition were also no difference in the 100 versus 200 milligram group. Oh, sorry. What we did find is the babies had the same FiO2, 46%, 45%, before surfactant. However, FiO2, 6-12 hours, were significantly lower in the group that got the higher dose. The area under the curve and the were also significantly higher. So I think these data are pretty convincing of a better clinical response with a higher dose. It was sort of reassuring for us that also the age of treatment was similar, but when we look at the green pattern, orange pattern, red pattern, and relapse, which I described in the previous slide, they all significant difference depending on the dose. The tau, which is the speed of response to surfactant, was also different, 4.4, 4.5 versus 3.3. And the number of doses, of course, was much less with the 200, as we expect. So I think all the data pointed in the same direction. And interestingly enough, oxygen therapy in this 149 baby was 1,025 hours versus 800 hours, P006. No difference in ventilation hour, no difference in CPAP, although the trend was in favor of 200. But interestingly enough, 25% BPD here, 14% BPD here. I do appreciate this is not a randomized studies, but we correct for everything. We didn't change anything in our clinical practice, so we are very much encouraged for this finding, and it's apparent to us that the BPD rate has changed as we introduce this change in clinical practice. If we want to look at the way FiO2 went, they were similar, the two groups. At 6 hours, you see this difference, and the difference in FiO2 persisted up to 32 weeks in this 140 baby in the two group. The last bit of information I'd like to share with you is that what goes wrong with BPD? Is the surfactant metabolism different in BPD? Is there anything we could improve, understand better in BPD patients? And this is a case-controlled randomized patient where we have 122 BPDs defined as a Walsh criteria, physiological criteria, 125 non-BPD matched by birth weight and gestational age, but not for sex. You can see male are significantly more frequent in the BPD group as compared to the non-BPD group. And the other statistical difference in the APGAR score, 7.3, 7.7, which of course, because the large number turned out to be significant, but I wonder what the clinical relevance is of this statistical significance. But otherwise, we feel we have reached a good match of the two groups. These are the prenatal risk factor, prenatal steroid preeclampsia. In the interest of time, I won't go through, but risk factors were identical in the two groups. Sorry. And what came out was the BPD infant had 48.2% FiO2, and this is also paralleled by oxygenation index, versus only 39 in the non-BPD baby with 0.005. 6 hours, there was a bit of tendency, but did not to be significant. At 12 hours later, the difference was again significant. Here, I apologize for the non-significant, which I hate, but the number is slightly superior to 5. I mean, but although it was recorded as non-significant. But of importance, the area under the curve and the gain were not different between BPD and non-BPD. So our interpretation of the story is this one, is that the area under the curve, 24.5 and 25.5 is identical in BPD and non-BPD infant, indicating that BPD and non-BPD respond to exogenous surfactant to the same extent. But because they start sicker or with a worse situation, look what happened. FiO2, mean FiO2 remain higher and higher from birth to 36 weeks. What is the underlying cause of that? We don't know. But of course, we have ideas, and we are doing study at the moment on this. So I come to a conclusion, and I hope I present you data and make a point that surfactant status differs greatly among selected conditions in premature infant, although we treat everyone with the same dose of surfactant. It is likely that the same dose won't suit the needs of all patients that we treat. This is our strong belief. Different surfactant doses have clinical consequences. I think I show you quite a few. And I think we have very strong data that indicate that 200 milligrams per kilo of poractan alpha is associated with better respiratory outcome, and it's probably one of the reasons why it's being incorporated in the guidelines. You will hear from David now that what changes and the new news on guidelines. Furthermore, I think we developed some mathematical model where we have a better way of assessing response to exogenous surfactant, early response, late response, relapse, and so on. And I strongly believe that the time is right to start with the clinical study in selected diseases in premature infant using different doses and different timing of exogenous surfactant. These studies, I think, they should be parallel to studies that try better surfactant administration. I thank you for your attention, and I thank Matteo Pasqualini, who is in the room, who helped a lot me in doing all the data, and all my engineers, the team. Without them, this type of work would not be possible, and all my colleagues, they were so patient to help me collecting all this data on surfactant response. Thank you very much.